Pancreatic fistulas after Whipple can be classified as clinically insignificant grade A or clinically significant, in which grade B has a duration of greater than 3 weeks and requires percutaneous or endoscopic drainage, and grade C, which in addition is associated with organ failure. Clinically significant pancreatic fistulas occur in 25 to 30% of patients and are associated with disease-specific risk factors such as smaller pancreatic ducts and softer glands, patient-related factors such as age, obesity, malnutrition, and the surgical techniques such as the type of anastomosis and blood loss. They are diagnosed with drain amylase levels greater than 3 times the serum amylase. Management involves supportive nutrition where enteral nourishment is as good as TPN. Octreotide may have mild benefit, but the mainstay of treatment is drainage, most commonly done percutaneously. Median duration of drains for grade B is 30 days and 40 days for grade C fistulas. We present 3 cases of grade B and C fistulas who failed percutaneous drainage alone and conventional ERCP, but were rescued with EUS pancreatic rendezvous. Their median age was 62 and median BMI was 40. They all had a soft gland, and the median pancreatic duct preoperatively was only 2.5 millimeters. Also, 2 of the 3 patients had intraoperative stents placed. Case 1. A 56-year-old male, 28 days post-Whipple, despite 2 indwelling percutaneous drains, was admitted with wound dehiscence and pancreatic juice leaking from his incisions and sepsis. A CT scan showed fluid tracking alongside the drain and through the ventral surgical incision despite an adequately placed drain near the pancreaticoduodenectomy. So the patient is taken for an ERCP to better control this leak. Frank pus is seen emerging as attempts are made to cannulate the pancreatic duct, with contrast injection and wire passage showing no discernible duct. On EUS, a 1.5 mm pancreatic duct is identified. The first attempt at a 19-gauge needle puncture and contrast injection is unsuccessful. The second pass, however, obtains a pancreatogram, but no contrast flows into the jejunum. A 0.025-inch angled guide wire is passed carefully, gradually pulling the needle back till the duct is ultimately cannulated with the wire. But the wire needs to be passed towards the pancreaticoduodenectomy. So with a steady needle tip barely in the duct, the wire is manipulated till it flips downstream. Now the wire coils in the dehisced space between the pancreas and jejunum. With continued and careful manipulation, ultimately we find the pancreaticoduodenectomy and the wire is passed into the jejunum. Note, the dehiscence is at least 3 if not 4 centimeters long. The scope is then withdrawn, leaving the wire in the pancreatic duct, and exchanged for a pediatric colonoscope, which is carefully advanced to the pancreatic limb without dislodging the wire. The guide wire is finally seen. Unable to snare it in this position, the wire is grasped with a forceps and pulled down to a more stable position to allow snaring it to rendezvous. The wire is carefully pulled through the scope while advancing the wire through the mouth. A 9 to 12 extraction balloon is then advanced over this rendezvoused wire and a pancreatogram obtained. The rendezvoused guide wire is then completely withdrawn and exchanged for a new 0.025-inch guide wire passed into the tail of the pancreas, over which a 7 French by 9 cm pancreatic duct stent is placed. Post-ERCP day 8, he develops another fever and CT scan shows a fluid collection closer to the tail of the pancreas consistent with an abscess. This is easily drained with a 10 by 10 mm cautery-enhanced lumen-opposing metal stent, which is then removed after abscess resolution 3 weeks later. Post ERCP day 72, he is taken for an ERCP to remove his stent, but there's still a space between the pancreas and the jejunum, and again a failure to cannulate the pancreatic duct, even though he is asymptomatic at this time. So he undergoes a second EUS pancreatic rendezvous, allowing placement of 2 7 French pancreatic duct stents, which after a dwell time of 6 months are removed at an ERCP. A patent pancreaticoduodenectomy is seen. A 0.025-inch guide wire is passed into the pancreatic duct, and a pancreatogram shows no more leak. He lived for an additional 33 months with no recurrent leaks or pancreatitis till he succumbed to his metastatic cancer. For the 3 patients treated with EUS pancreatic rendezvous who had failed ERCP, they had a median of 2 drains for a median duration of 30 days prior to the EUS. Median pancreatic duct size on EUS was small at 2 mm, and we used 1 or 2 7 French stents in all cases. Percutaneous drains were removed after a median of 20 days after the EUS, and the median stent dwell time was 210 days. Median follow-up was 33 months with no adverse events or recurrences. Postoperative pancreatic fistulas after a Whipple that are clinically severe, grades B and C, may sometimes fail management with percutaneous drains alone. Conventional ERCP may be difficult if there is a large dehiscence. EUS pancreatic rendezvous can help bridge these leaks, but can be challenging due to the decompressed pancreatic duct. Careful needle puncture and wire manipulation can allow access and reconnecting the disrupted duct to the jejunum. Median time to drain removal may be shortened in these situations. In conclusion, when percutaneous drains and conventional ERCP fail to bridge a severe post-operative pancreatic fistula after a Whipple, don't give up. An EUS pancreatic rendezvous can help reconnect the disrupted duct to the jejunum and possibly hasten recovery. Further studies are needed to compare this approach to percutaneous drainage alone.